Hi everyone, I am Dr. Vinay, Assistant Professor UN Mehta. Today we will discuss about aortic regurgitation, especially the surgical aspect of aortic regurgitation, how surgically we manage it and how are the outcomes of various procedures. Aortic regurgitation occurs when there is an inadequate closure of AV aortic valve leaflets, which leads to abnormal retrograde flow of blood during the cardiac diastole. It can be due to damage or dysfunction of aortic valve leaflets or distortion and dilatation of aortic root and ascending aorta. These are the etiology of aortic regurgitation according to the chronicity of regurgitation, acute AR and chronic AR. These are the most common causes. Okay, for the assessment of AR, main diagnostic modality is echo. In echo, we assess about the aortic valve structure and morphology, any presence of any vegetation, and we assess severity of aortic regurgitation. We assess severity by this color Doppler jet width, vena contracta width, or regurgitation volume fraction or orifice area. And we also look for the premature closure of mitral valve, which signifies severe AR. We also assess associated lesion of aorta like dilatation, aneurysm, or dissection. We also assess left ventricular structure and function. Echo is the main modality to assess, diagnose, and assess the aortic regurgitation. It also helps to categorize its severity. These are the classification of AR according to severity. We assess this jet width, vena contracta width, regurgitation volume, ml per beat, regurgitation fraction, and regurgitation orifice area. According to these variables, we divide this AR into mild, moderate, and severe. Usually, this is the angiographic grading of AR. Next, these are the indication for surgery in severe aortic regurgitation. Usually for mild and moderate aortic regurgitation, medical management is applied. While for the severe aortic regurgitation, these are the indication for the surgery. Like any symptomatic patient with severe AR, we go forward and plan for the surgery. For the asymptomatic patient, if left ventricle EF is less than 50%, still we plan for the surgery. Surgery is indicated in patient undergoing for other cardiac surgeries like CABG or ascending aorta surgery or other valve surgery like mitral valve. If there is severe aortic regurgitation is present, we address it. Other in asymptomatic patient, we also look for the this LV function, the pointers which shows LV function is compromised. We plan for the surgical intervention like resting ejection fraction and severe LV diastolic dysfunction like in diastolic diameter more than 70 mm or in systolic diameter more than 50 mm. Or in left ventricle in systolic diameter greater than 25 mm per meter square BSA. These are the indication of surgical intervention in case of severe aortic regurgitation. These are the indication of surgery in case of aortic root or ascending aorta aneurysm. Surgery is indicated in patient who have aortic root disease with maximal ascending aortic root diameter greater than 45 mm in case of Marfan syndrome or other connective tissue disorders. And in case of bicuspid aortic valve, the range is greater than 50 mm, and all other patient it is greater than 55 mm. Surgery And preferred approach is aortic valve sparing surgeries whenever it is possible. If not possible, go for the standard Bental procedure. And for clinical decision making, dimension of aorta should be confirmed by ECG gated CT measurement. This is the chart for the management of aortic regurgitation. First, we look for the enlargement of the ascending aorta. If it is present, it is greater than the cutoff value, like 4.5 centimeter in case of Marfan syndrome, or 50 mm in bicuspid aortic valve, or 55 mm in other patients. If it is present, we plan for the surgery. If not, and still severe aortic regurgitation is present, and patient have the symptoms, we plan for the surgery. And still patient have no symptom, patient is asymptomatic but having normal, having severe aortic regurgitation with normal ascending aorta, then we look for the parameters of left ventricle, like ejection fraction is less than 50%, or in diastolic diameter greater than 70 mm, or in systolic diameter greater than 50 mm. Then if these criteria are fulfilled, we plan for the surgery, else we plan for the follow-up. We keep these patient in regular follow-up. This is the algorithm for management of severe AR. If we have a patient of severe AR which is as diagnosed and assessed by 2D echo, then we look for the status of ascending aorta. If it is dilated, then we look for the status of the leaflet. If these are leaflet are good coopting leaflet, quality of the leaflet is good, not thickened, commissure is fine, then we plan for the valve sparing root surgery, like remodeling or reimplantation procedures. If the leaflet are not in good state, they are thickened, commissure is fused, or calcification is present, then we plan for the Bental procedure. And in case of severe AR, if patient has normal ascending aorta, then again we look for the status of the leaflet. If it is repairable, always try to preserve the native valve. If not, we plan for the aortic valve replacement. These all are valve repair procedure, which can be divided in broadly in three categories, like cusp repair procedure, aortic root techniques, or annular techniques. In annular techniques, usually external annuloplasty procedure are included. In aortic root techniques, these valve sparing procedures are included, like David or Yakub procedure. In cusp repair procedure, various types of repair techniques like central plication, or this paracommissure plication techniques are included. Now the functional anatomy of aortic root. This figure shows all the component of the aortic root, like right start from sinotubular junction, all three leaflets, sinuses, and inter leaflet triangles, and this aortic ventricular junction. These all components make the aortic root. The aortic valve leaflet inserted at the annular, which is aortic annulus, which is crown shaped proximally at aortoventricular junction and distally at sinotubular junction in a crown shaped manner. Where the leaflets are inserted, it is called as functional aortic annulus, which is the junction of sinotubular junction at one part and aortoventricular junction at the other end. The integrity of all the components are necessary for the good valvular function. This figure shows this aortic root anatomy, right from the sinotubular junction to the crown shaped insertion of the leaflet, and on this functional annulus. In normal aortic valve, cusp coaptation relatively constantly reach the mid-level between the aortoventricular junction and sinotubular junction. Certain degree of individual variation present in the length ranging from 2 to 6 mm. Although coaptation of 2 mm is enough to ensure the valve competency in an functional aortic annulus of normal size, longer coaptation may present in some patients. This figure shows various parameters like effective height of leaflets, coaptation height of leaflets, annulus, sinotubular, relation of annulus and sinotubular junction. Now we discuss various options, surgical option, the valve which is salvageable, the valve which is not salvageable. First, why we need to salvage the valve. First and foremost is the avoidance of anticoagulation. Second, natural valve has better hemodynamics. Third, there is a low incidence of infective endocarditis in native valve. Which valve is to be salvaged? First, the leaflet, normal or near normal leaflet, predominantly isolated regurgitation, cusp prolapse, perforation, central AR due to dilated aortic root. Preferred valve sparing is preferred in young age to avoid the anticoagulation, plus the benefit versus risk ratio of repair failure versus anticoagulation. Uh, Other thing is which valve is not to be salvageable. First thing is calcification. If severe calcification is present along the cusp or annulus, it is difficult to spare or repair this valve. Other thing is cusp thickening, extensive fenestration of cusp, especially near the commissure, severe infective endocarditis. Okay, these are the goals which we kept in our mind during the valve repair. First and foremost goal is to restore a functional surface of coaptation without any leak and durable repair. This is the valve analysis and pathoanatomy of aortic regurgitation of a valve. We can say this is the functional classification of aortic regurgitation. On one side of the slide, it is the category of the dysfunction. On the other side, the lesion associated. Type 1, where the leaflets are normal. Usually, the lesion associated is dilated sinotubular junction or ascending aorta, or any cusp perforation which lead to aortic regurgitation, but the leaflet motion is normal. Type 2 is excess leaflet motion. Associated lesion is cusp prolapse or commissural disruption. Third, in type 3, there is a restricted leaflet motion. Associated lesion is commissure fusion or valve thickening or calcification. This is further same classification. Type 1 with normal cusp motion associated with dilated functional aortic annulus or cusp perforation. Type 2 is cusp prolapse, type 3 is cusp restriction. Associated lesions and repair technique in type 1, type 1A, which is dilated STJ. So ascending aortic graft is sufficient for these. Type 1B is aortic valve sparing techniques, right? Reimplantation and remodeling techniques. Third is this cusp perforation. Third and 1C, 1D is patch repair, autologous or bovine pericardium. And type 1C is your STJ annuloplasty is sufficient. Then type 2, there is a cusp prolapse. We have various for the repair technique, all the leaflet repair techniques like plication, resection and suturing, free margin, resuspension or patches. The last type 3 is cusp restriction. These are thickened leaflet, these lesions have thickened leaflet, so Then the repair techniques are shaving, decalcification, and patch repair. This is other aortic, these types of aortic insufficiencies: 1A, 1B, 2A, 2B, and 2C. These are the associated lesions and repair techniques. First, during repair, first step is the assessment of valve, which we should kept in our mind. First is assessment of valve type, number of leaflet like bicuspid or tricuspid or unicuspid valve. Type, if bicuspid, then type of the fusion, type of the bicuspid valve, commissural orientation, or fusion completely fused or incompletely fused. Second, any degenerative changes. All the leaflets are mobile, pliable, and free of calcification. It is ensured it is present. It is the prerequisite for the long, durable, and sustainable repair. Third is detection of any detection and assessment of any fenestration. Their presence is not a contraindication, but if large fenestration present near the commissure, it make difficult. Third, we assess the this geometric height of all the specific ruler for this purpose. For the feasibility of repair, the leaflet has to a sufficient amount of tissue. If not, leaflet is assessed for any restriction. A restrictive leaflet is classified if geometric height is less than 17 mm in tricuspid aortic valve or less than 20 mm in bicuspid aortic valve. Restrictive morphology, even if present in one leaflet only, make the repair option dubious, and valve replacement has to be considered. Measurement of effective height of all the cusps by mean of dedicated aortic caliper. The effective height should be equal in all the leaflets within a range of 9 to 10 mm. Lower effective height indicate the leaflet prolapse, which is commonest leaflet pathology in regurgitant aortic valve. This picture shows how we measure this effective height and coaptation height. Now these are the cusp repair technique. First, cusp prolapse repair. These include free margin or central plication, cusp resuspension, triangular resection, and paracommissure annuloplasty, like Trussler techniques. If for cusp fenestration, free margin resuspension or patch repair. For cusp restriction, cusp saving or resection, or cusp augmentation using pericardium. Now we discuss in detail each techniques. First step in any technique is this assessment suture. This figure shows the technique. First technique is central free margin plication. It is the commonest intervention on the leaflet. It is performed in delicate steps on the both side of nodule by the mean of monofilament suture. The suture is passed from inside of the sinus of Valsalva through the edge of leaflet just adjacent to the nodules out and back again on the other side of the nodule. At tying the suture, the central fibrous nodule is invaginated inside and a smooth coating surface is created. Additional plication suture, if required, can be taken. This figure shows the technique of central margin plication. Other technique is free margin resuspension. Leaflet edge resuspension was by the oversewing, by the shortening this leaflet. Currently, it is rarely used. It can be used in a case of fenestration bridged over the very fragile cord. This is the technique. This figure shows the technique. The other technique is paracommissure plication or Trussler's repair. In this technique, we plicate one of the leaflet near the commissure using a placed suture. This figure shows other plication technique, subcommissural plication technique, durance repair. In this technique, all the three leaflets are plicated near the commissure. This is very easy, simple, reproducible intra-aortic technique that reduce the aortic annulus circumference at the level of interleaflet triangle, uh, effective in the significant reduction of aortic annulus, thus increase the effective height of leaflets and copting surface. This figure shows the triangular section of redundant part of bicuspid leaflet and resuturing. This figure shows the pericardial patch repair of cusp perforation. The type 3 lesion have leaflet restriction due to leaflet thickening. So the technique used are cusp saving resection and patch repair. This figure shows the cusp augmentation using pericardium, autologous pericardium or bovine pericardium. This figure also shows the pericardial patch augmentation. We especially talk about bicuspid aortic valve. This figure shows the classification of bicuspid aortic valve, which is based on the presence of raphe. Type 0 is where is a true bicuspid aortic valve. There is no raphe present. Two equal leaflets with two coronary ostia, which may present on each side of sinuses or same side sinus. Type 1, when there is a one raphe is present, true raphe is present. Type 2 is when there is a two raphe are present. So it is easy to repair to make it tricuspid valve. These are the types of bicuspid aortic valve and techniques used to correct the prolapsing cusp or restrictive cusp. This figure shows the systematic approach to repair of aortic root and cusp pathology in regurgitant bicuspid aortic valve. Two important parameters are aortic root size and cusp anatomy. This figure shows the algorithm. This is type 1 bicuspid aortic valve with one true raphe. The figure shows that non-calcified median raphe is present, which is resected, and which can be resected and leaving behind the intact leaflet. This is other type 1 bicuspid aortic valve. Here the raphe is calcified and restrictive. So we resect the raphe and again resuture the leaflets. Or we can use pericardial patch if it is if we cannot perform primary tension-free repair of the leaflet. Then dystrophic aortic insufficiency, characterized by the dilatation of aortic annulus sinuses or sinotubular junction, preventing the coaptation of the leaflet. An aortic annulus diameter larger than 25 mm and sinotubular junction diameter larger than 30 mm are deemed as a functional dilated. Reduction of STJ induces a symmetrical prolapse by lowering the effective height of the cusp, while dilatation of aortic annulus diameter reduces mostly the coaptation height. This figure shows the relationship between sinotubular junction and aortic annulus. The ratio is 1:2. These are the various approach used for the surgical management of dilated aortic root, dilated ascending aorta, and isolated. In dilated aortic root, we can use remodeling and annuloplasty technique. In only dilated ascending aorta can be replaced. Annuloplasty techniques can be divided in extra-aortic rings or intra-aortic rings, subcommissural annuloplasty, or other techniques. These are the some annuloplasty rings for aortic valve. This figure shows the technique of external annuloplasty with an open ring. The desired sized annuloplasty ring, open ring is used, which is sutured around the aortic annulus. Lastly, it is adjusted with the suturing the both end of the open ring. Dilated sinotubular junction also result in a non-coaptation of aortic leaflets. It is usually corrected by replacing it ascending aorta with Dacron graft. This figure shows the technique. The reduction of dilated sinotubular junction is achieved by isolated supracoronary aortic replacement. The chosen size of vascular graft meant a new diameter of sinotubular junction. Principle of surgical reduction of STJ is also present in the complete aortic root replacement by a vascular graft. This figure shows the correction of sinotubular junction. Now the treatment of dilated aortic root. Classification and nomenclature for the root sparing techniques. David procedure is a reimplantation procedure. That means reimplantation of aortic valve in a tubular vascular graft after complete excision of dilated aortic root valve wall is one of the principal surgical aortic valve sparing technique. This is the original paper describing the technique. The other technique is Jakob's technique, which is a remodeling technique. This is the original paper for the remodeling this remodeling technique. This figure shows the comparison of the both remodeling and reimplantation technique. The various differences, the cusp motion, which is greater in remodeling technique than the reimplantation. Valve stability is same in both, and the stability of aortoventricular junction is present in reimplantation, which is absent in remodeling technique. This chart also compare both techniques. So, conclusion from these studies that aortic valve repair is an acceptable therapeutic option for the patient with aortic regurgitation. The functional classification allows a systemic approach to repair these aortic regurgitation lesions, especially in the rheumatic aortic valves. Thank you.